Well, good morning. I'm Terry Albrecht. I'm Associate Center Director for Population Sciences at the Barbara Ann Karmanos Cancer Institute in the center, the heart of Detroit, Michigan, where I also serve as leader of the Population Studies and Disparities Research Program. I'm also professor and division chief in the Department of Oncology in the Wayne State University School of Medicine. As a communication scientist, who's been working in studies of health disparities and social and behavioral determinants of health for about 35 years. The area of informed consent, the area of accrual to clinical trials has been a focus of the work that I have done and the beautiful work that members of my team have done for a long time. So I really thank the IOM panel for inviting me to speak a little bit about our work over the course of time, and hopefully it will add to this very important conversation. And I also would like to thank the first two speakers, who I think have very nicely set up this presentation for me. We're following up on the idea of the consent process having several aspects to it, many of which are broken, not just issues related to the form, but the consent process includes developing appropriate IRB-approved consent forms, discussing those consent forms with patients, which I will largely talk about, and then gaining the signatures as documented consent. Ideally, the process of obtaining consent for participation in a clinical trial is extensive and comprehensive. So writes Dr. Lydia Shapira and her colleagues at Harvard. The process should address the patient's expectations and concerns and may require more than one visit. The degree of effort involved is hardly reflected by the signature obtained in the document procured during this process. So let's talk a little bit about that, that idea of that signature. And, as a bit of a conceptual framework to wrap around this process, the signature is supposed to represent informed consent. Well, as you look at the consent matrix, it's really but one quadrant. As we know, the process is more complicated than that. In reality, there is informed refusal, hopefully. There's also uninformed consent, and poignantly, there is uninformed refusal, where patients are in a position to refuse something that they've really not been informed about very well and really don't know potentially what they might be missing. Informed consent discussions in communication science terms follow very nicely the model of convergence, which has been in the communication literature for a long time. If we have a state of informed consent or a state of informed refusal in these terms, we have what's called convergence, meaning essentially a shared sense of accuracy and agreement about what was said and what it means. The research protocol as an option to standard of care, is understood, that's shared, and there is accuracy about what patients, family members, and their companions say how this is defined. There's also the issue about the extent to which that they overlap around these definitions, around the details, around the topics that were discussed. What we talk about with convergence is not complete mutual understanding. For us, as human beings, that would mean that all these circles would be perfectly concentric on top of one another. When was the last time any one of us in this room ever felt completely understood, even by the people closest to us? Let alone, what we projected to think that other people fully understood about what we were saying to them. Typically, we overlap just enough so that we can proceed ahead. There is a sense of satisficing, as many system scientists have talked about. And what that means is that we have a level of understanding that's created where we have a necessary and sufficient information overlap in order to make an informed decision in terms of care. Looking at this a little further, a way to think about what's necessary and sufficient for assessing the level of shared agreement and shared accuracy about what was said and how it was said and what it means, is to say that we have a shared sense of agreement over what was said, what were the topics, how were they explained. We have shared accuracy in that independently we can verify what one another has said about this. And we have shared agreement, and it is shared agreement, not necessarily shared accuracy, but shared agreement about the implications of what was said. If you tell me about my side effects and you tell me how you're going to take care of me in terms of the likely side effects that I may experience, there are no guarantees about that, as we know in medicine. And so if at least we have some agreement about the implications of what I may experience in those side effects, and that we open up the opportunity for further dialogue and for you to help in my care going forward. These are the kinds of things that we want to how we want to phrase this and how we want to present the ideas. Our research has shown that in clinical interactions among patients, family members, and oncologists, they tend to agree on the topics that were said, and no surprise, very little agreement about what was said regarding the details of those topics. So let's look at some data. Inside the black box of clinical trial discussions, we've been looking at analyzing physician-patient interactions over 3 decades. I've got a lot of data here. It's a real retrospective. And in looking at this since the mid-1990s, we've been video recording what's said and how it's said, who's in the room, who's not in the room. We focus here, though, and I emphasize this, we focus on the very sacred relationship between the patient and the physician. I know that there are a number of other professionals who are involved in the consent process: clinical research nurses, other kinds of patient advocates, social workers, a number of support personnel who are there. But in terms of the patient's mind, again and again over the course of the studies that we have done, it is that relationship and what is said and how it's said between the patient and the physician, and also the family member or other companions that are present, where all of this starts. It's where that consent form is transacted and where the patient is, set up to think about how they're going to read this consent form, if indeed they do read it. I just would add, we have a video data archive, certainly IRB protected, set up for and with a number of safeguards, but it's of over 1,000 of these interactions where we have learned so much about, again, the poignancy of what happens in these transactions. About half of those interactions have to do with the informed consent process around clinical trials in cancer. So let's first start. I want to talk about, on the previous slide I had a set of observable factors, very simple ones. And you'll probably look at this and think, aren't you a little bit more sophisticated in your analysis of these tapes? And certainly we have a number of ways in which we look at this. But from the informed consent process, we have been amazed at just how you can ask some simple questions and get some very complicated kinds of responses. First of all, when the physician and the patient first talk about the option of a clinical trial, is the consent form present? Early on, this was the very first encounter that we ever video recorded in 1995. And in this case, the physician is saying, so what we're going to do, he says, is go through the consent form. You'll get a copy of it afterwards, so you don't have to, and he goes on. So you get an idea of this. This physician here in 1996 was a protege of the original physician, and one of the things that's important about that is that physicians again and again tell me that they have very little training, haphazardly, but very little training in how to present consent forms to their patients, or the option of a trial, even introducing it in a general way, and they tend to do what they've observed others doing, particularly their mentors when they were fellows. We have another situation where you have the physician and the patient on the same side of the table. The physician is going through the form, making all kinds of notes on it for the patient. And in this case, he's saying that there would be another randomization for you to see whether or not, giving additional chemotherapy would be helpful. And he's circling things and going through these and basically breaking down each step with her. Took a long time, as you might imagine, although when we did this work, I will have to tell you that it didn't take any longer for physicians to use this kind of method than not use this kind of method. Surprisingly, this somehow became somewhat of an efficient way to essentially choreograph these encounters. In 2007, as we moved, closer and closer in time to the present, I seldom ever see a consent form in the room with the physician's hand on it. In this case, we have the physician talking to the patients. I think we, in, again, very general terms, and the clinical research nurse will presumably follow. In this case, however, you do see the patient is taking notes on what's being said. In the photograph here below, the screenshot below, we have a patient in a wheelchair who's not feeling well. The consent form is being discussed, but again the thing that we've noticed is a very interesting relationship between whether or not the consent form is in the room, and the extent to which there is give and take in the discussion between the patient and the physician. In these cases, there are very few questions being asked, and it's largely a very directed kind of linear discussion. Second question is, who's present? This is important to ask because in the work that we've seen, we see that 82% of our white patients bring one or more companions with them to the visit. Only about half of our African American patients have someone else in the room. So why is this important? Well, we know that patients and family members ask about the same number of questions. But when you don't have someone there with you, by definition then, you have about half as much information transacted in that encounter. African Americans generally ask fewer direct questions anyway, and so we see something of an information disparity here, which again, is going to have some implications for the level of informed consent going forward. If we look at the idea of how much consent information then is discussed, we can observe this very easily with checklists of the kinds of things that are on a consent form, and so the kinds of things that do get addressed. And I'll just have you think about two columns. Under the non-accrued, these were the people who refused the clinical trial. All right, and so if it was discussed, this is informed refusal, or at least an approximation, an indicator perhaps of that. If the patient went on the study, we'd like to think that this represents informed, this is informed refusal, and this is informed consent. All right, so how many of these different items, just in a real raw checklist way, were covered? These are data that we reported 15 years ago in a Journal of Clinical Oncology, and I'll have you say that probably if we want to keep score, we can say that they were pretty good at the study purpose being explained. Certainly in terms of the treatments and types of tests were reviewed. We see that the study procedures were reviewed, and we also see that the alternatives to the study were reviewed. Just how much of that went on and just how whether or not the patients understood what was being told to them, of course, are different questions. But just from a raw checklist standpoint, these are the kinds of things that we were seeing. As we go to the next slide, this is a little bit more recent data from our R01, and in this case, what we were looking at is, again, how much information was covered. If you really just pay attention to this sort of top list here of the checklist items from the informed consent document, the score could have ranged from 0 to 19. Obviously, not everything is going to get discussed, but we do look carefully at what was discussed. And they're talking about just about half the topics that are in the consent form. And again, you know, as we talk about how we package information for patients, how we set them up for how we're reorganizing the consent form itself in terms of most important, less importance, and so on. You know, some of these things with the patient's perspective on this may help us think more in terms of how we might order the primacy, the recency, and the extent of this information that's provided. I do offer, you know, suggest that we spend a little bit of time on these two kinds of things. The reassurance and support about the consent decision. You know, if you don't want to go on this study, we'll continue to see you here. You know, I believe it or not, patients tell us they want to hear, will you be my doctor if I don't go on the study? If this, and especially if this is the study physician is the investigator. You know, it's also very important to say to patients, if you're not doing well on this study, we will reevaluate and decide then what to do for you. And I'll show you in a minute, you know, an example of, you know, of the fact that that is still very much in patients' mind about whether or not they're caught on something that's actually harming them. The other thing that we've discovered from a social scientific, social psychology perspective, is that patients are not afraid of side effects, at least in our studies. What they want to hear is what you're going to do for them if they do encounter those side effects. So I'm going to lose my hair, or my temperature's going to spike. And we've seen some, you know, incredible examples of how physicians have used that as an opportunity to provide even more patient-centered care to the patient in talking about, we have a wig salon downstairs, they're nice people, you'll go down there, they'll type your hair, most importantly, you'll have the wig when you need it, if you want it. And that, you know, again, using this as an opportunity to extend the level of care and emotional support that is often difficult sometimes for physicians to provide. As we move forward here, we still need to ask the question, is the trial recommended during the consent discussion? This makes people uncomfortable. It's a controversial item because recommending a trial to a patient is sometimes seen as invoking undue influence on the patient's ability to make an informed and, most importantly, an autonomous decision. We've studied this and found that, well, yes, indeed, at least in our study, that the physicians are recommending the trial. They're making a recommendation very, you know, significantly more frequently. And they're making what we call an unprompted recommendation. We've seen the cases, and certainly we've seen them in our data, where patients will say, well, what would you tell your mother to do? Or, you know, what do you think I should do, doc? And but these, you know, that would be prompted. But the unprompted is where the physician recommends the study and says, I recommend this study, all right, as, you know, as a way you should go. And that is the key question. Is it individualized or general? This is a good study. I recommend this study. And again, a lot of those kinds of phrasings are of questionable, have some ethical controversies surrounding them. But I'm, you know, relaying to you the way that this is phrased with patients. But what's interesting is that so often the recommendation that's made is that I think this is a good study for you. And so the individualization of that really even, you know, moves it further. And again, what we're learning here is that 85% of the patients who received recommendations like this went on the study. So one more question we have to ask is, what's an offer? Offer rates are low. We know that we have insufficient numbers of patients agreeing to enroll on studies, often because we don't have, at least where we are, the kinds of studies for which our patients are eligible. So at any given time, what percentage of patients are eligible for the studies that are being offered by your institution? We do find, however, that when offered, patients do enroll, at least in, you know, RR1 and other studies since. But patients have misconceptions about what offers really represent. When we've talked to them a week after they've had these encounters, we find, for example, that 39% of the patients who only discussed a trial as something possible, thought they were offered a trial, and in fact sort of thought that's what was going to happen. But it hadn't yet. 14% of the patients who were actually offered a trial, where they could say yes or no at the time, so, you know, the offer was very clear, and they essentially said, you know, I wasn't offered a trial, and in a couple of cases, it's only an N of 2, I think, but I still would say, you know, they had signed, and we had the document, the video that they had signed. They still didn't think they were on a trial. So, you know, one more thing to think about, and that is, you know, is this a monologue or a dialogue in terms of the patient visit? John Wilson at the University of Ulster in Northern Ireland, of all places, has done work for many, many years on the idea. He's a sociolinguist, has done many years of studying what's a conversation and who has speaker rights. And you know, in this case, what we're looking at here is, you know, the idea of a patient who sits and does not change position for 11 minutes while a very long, very caring monologue went on about the study. And there was one question at the end, and they decided at the end that she would start treatment that afternoon. In this case, we have the physician saying, "Are you familiar with what a clinical trial is?" The patient says, "I've heard about it." Physician says, "Do you know what I'm talking about?" Physician said, "What's your idea of it?" Patient says, "My idea is that you go into trials. You try this drug, and then they take data from what's going on with you." Physician says, "Yes." She says, "Yeah, no, I don't know. The only thing about, I don't know if you can get out if you want to or if you have to stay in." And he says, "Yeah, okay, you know, you're actually very close. First of all, you can get out, okay? You can get out of the trial if you need to." And it goes from there. I mean, we're really starting way back at the baseline with this. And finally, is racial bias evident in the discussion? And unfortunately, in the cases we've seen, yes, blacks receive less information about trials than whites do, particularly when it comes to the purpose of the trial and the risks of the trial. So in summary, I'd like to say that protecting human subjects is about informed consent and informed refusal. And these things begin with the physician-patient-companion interaction. The quality of the interaction, we believe, is related to the extent to which all parties achieve communicative convergence, which is a level of sufficient mutual understanding that carries with it shared accuracy and agreement about what research participation means. The level of convergence is related to the relational and informational experience that is part of that dialogue, and that consent is a process of giving balance to the rights to speak as a way to achieve the rights to be informed about research. Thank you.